We are challenged regularly clinically with corneal infiltrates, which we need to differentiate between infectious versus non-infectious. Infectious infiltrates are important to identify because, as its name implies, it's caused by a microorganism that invades the corneal tissue. Now, these patients usually experience significant pain. The infiltrate is usually a single large area that stains with fluorescein and is commonly surrounded by corneal edema. Oftentimes, there will also be significant discharge from the eye. Because the cornea is being invaded by a microorganism, the patient may have an anterior chamber reaction and significant light sensitivity secondary to the anterior chamber reaction. In fact, if an anterior chamber reaction is seen in the presence of an infiltrate, assume it's infectious until proven otherwise. Infectious infiltrates are most commonly bacterial in nature, and as such, high quantities of topical antibiotics are typically used as first-line therapy to treat these infiltrates. Fourth-generation fluoroquinolones, as seen here, work remarkably well. In the most severe cases, topical antibiotics are initially dosed on the affected eye as frequently as every 10 minutes for several hours. Now, non-infectious infiltrates can present clinically in a number of ways. Peripheral ulcers are typically caused by inflammatory mediators that have accumulated in the peripheral cornea, causing fluorescein uptake. Diffuse infiltrative keratitis is seen as infiltrates that are spread throughout the cornea. They may demonstrate late-phase staining with fluorescein. Although considered benign and usually self-limiting, if left untreated, can cause significant inflammation and neovascularization, as seen here. Usually non-infectious infiltrates are much less aggressive and are less symptomatic than infectious infiltrates. Non-infectious infiltrates will respond well to corticosteroids, but oftentimes combination antibiotic steroid agents such as Tobradex ST and Xylit will be utilized because although the infiltrates are not infectious, the antibiotic will help reduce the level of microbial flora, reducing the exotoxins that bacteria may be producing, which can exacerbate the infiltrative response. Both infectious and non-infectious infiltrates are often caused by contact lens abuse. It's critical to differentiate between the two. Fourth-generation fluoroquinolones work remarkably well for infectious infiltrates. If you've ruled out an infectious etiology, consider either topical corticosteroids or a steroid antibiotic combination, and assure clinical resolution by following these patients closely. Keeping these things in mind will help improve patient outcomes, which is ultimately why we do what we do. We hope that this has been clinically insightful.